Our next lesson is going to be on indirect care. We're going to touch base on what indirect care is and how we can apply it um, to our resident care and the things we'll be doing and assisting them with. So, what is indirect care? Now, indirect care is going to include things like infection control, safety, communication, our residents' preferences, their needs, their comfort, and their rights. So, it involves a lot of very, very important things. Now, some things that are going to be important and the things that they're going to be looking for, not only on the state exam, but in real life, is that we're greeting our residents. We're always addressing them by their name, that we're introducing ourselves as well as we enter the room. And we always want to make sure we're providing explanations to our patients about the care, not only during care, but also before. So, explaining what we're going to be doing and then also explaining to them as we're doing it. Using standard precaution and infection control measures when we're providing care is going to be extremely important. So, making sure basically we're washing our hands when we're supposed to, putting on gloves when we're supposed to, take them off properly, things of that nature. We'll get into more detail of what those things are in a little bit. We always want to make sure that we give our patients or our residents choices and preferences during care. So, things like water temperature, how much toothpaste they want on their toothbrush, what they want to eat, different things of that nature. We always want to make sure we're asking about comfort throughout care. So, comfort can be things about them double checking the temperature of the water to make sure it's a comfortable temperature from them, making sure before we leave the room they're in a comfortable position. Um, always looking at comfort. Residents' rights, we're going to talk about here in a second, and we'll explain exactly what residents' rights are and how we can assist in making sure we're always promoting them. And then, like we talked about before, safety is always going to be our number one priority with our patients. Always making sure that everything we do with them and for them is safe. So, the first thing we're going to get into here is residents' rights. So, every patient or resident that is in a nursing home facility or any facility has specific rights. Um, like right to quality of life. We want to make sure we're giving them the best possible quality of life while they're in our facility. We want to make sure we're giving them the right for privacy and confidentiality. So, not only following HIPAA, but also making sure whenever we're providing care that we're giving them that privacy, shutting the door, pulling the privacy curtain, keeping them covered as much as possible. They have the right to have personal choices, and that's where we talked about in the previous slide, making sure we're giving them choices as much as possible anytime we're assisting them. Once again, that can be things like asking about water temperature, what they want to wear for the day, um, how much toothpaste they want on their um, toothbrush. Anything and everything that we can give them an option for, we want to make sure we're giving them an option. They have the right to complain, and like I always say, and everybody will complain at some point in time. But they have the right to not only complain. If you've ever been in a hospital nursing home setting, you'll notice they always have like complaint forms throughout the facility. So if a patient would like to complain, we want to make sure as the CNA that you're going to the nurse, letting them know about the concern, and if they would like a complaint form, they have the ability to fill that out. And then most places have a board or a group of members that will look at the complaints and address them as needed, making sure these complaints are being seen, they're being heard, and they're being followed through with. They also have the right for dignity, respect, and freedom. So the freedom to make their choices, making sure we're always treating our patients with dignity and respect. They have right to security of personal possessions. So what this usually means is, as always, I would encourage our patients, if they have something that's of value to them, to always, if they have somebody they trust, I always encourage them to give it to them for safekeeping. However, not everybody has that. So, a lot of times what we'll do is we'll supply them with a little lockbox where there's a key or a code they can put in, um, so they can have all their stuff in a secure place. Um, they have the right with regards to social services. So that means that medical social worker, they have access to them. They can reach out to them for those resources and things that they may need. So, what we should be looking at are what can we do to promote residents' rights? What what part of our job plays a role in this, and throughout each skill, how can we do it? So there's a few key things in how we can protect residents' rights. One of them's simple, something once. Again, I should never have to say, but unfortunately, this happens way more than people realize. We should never abuse a patient or a resident or anyone for that matter. Anytime we see abuse happening, it's been reported to us, we need to report abuse immediately. So anything we know about abuse needs to be reported immediately, following the chain of command, which we'll get into abuse, how to report it, where to report it, what abuse is in future lessons. Um, we want to make sure we call the resident by the name he or she prefers. So we shouldn't use the terms honey or sweetie, but if Jane wants to be called Jane or she's a nickname, always call him what he or she prefers. We want to making sure we're involved the residents in planning and always allowing them to make choices, making sure we're explaining procedures to them before and during it, making sure we're not necessarily exposing them. So, for example, if we're giving a bed bath and we are cleaning the patient's arm, we should have their entire body covered except for the arm. So, only exposing the areas that you're working on. Privacy is going to be a huge part of everything, especially on the state exam, especially in real life. Our goal is to keep them covered up to the shoulders as much as possible. Only exposing the areas that we're specifically working on. Now, this one's always a catch-22, but we have to respect their right to refuse care. They can refuse any care that they want, from medications to showers to um, bed baths to food and everything in between. Now, there's certain ways that we can handle this. There's certain things that we can do to try to avoid refusal of care. Um, so some of those things are: one, we do not count it as a refusal of care unless we've attempted 3 separate times to assist and encourage the patient to cooperate with care. So, what that usually looks like, an example, some suggestions, is sometimes it's all about how you approach it. How you talk to your patient, getting to know your patient, what they do and don't like, and the timing of when they do and don't like to do things will be good as you start to learn and get to know your patients. But the approach is everything. Not just walking in, all right, we got to get you in the shower. That's probably not the best approach to it, in regards to sometimes it's okay to say it, but you want to, how are you doing today? Get to talking to them, build that rapport, and then bring that up instead of just automatically jumping in and saying that's what we're there to do. Now, say that they refuse. No, I'm not. Maybe, maybe can we do it tomorrow? Whatever it may be. Um, what I usually do is, okay, you know what? I'll come back and check on you later. Maybe you're busy. Maybe they have something going on. There can be more than meets the eye. So we'll give them a little break and we come back a little bit later. When I come back later, what I usually do is ask again, and if they refuse care, then sometimes I try to just explain why it might be important. Now, this isn't there to lecture them, treat them like they're a child, or anything of that nature, but sometimes they may forget when the last time they took a shower is, how long it's been, um, what's going on that day, and why it might be a good time or a good day to take a shower, bathe, or whatever you're trying to get them to do, as far as their care plan is concerned. If that doesn't work, then we want to try a third time. So a few of the different things that I've tried before are: one, um, what I could do is have another Cena try. So, hey, Joe, can you do me a favor? I'm having a real hard time with Mrs. Smith. She's not letting me take, she doesn't want to take a shower for me. Do you mind giving her a shower and I'll take over your hallway? Maybe she'll warm up to you. Sometimes just a fresh face does the trick. Sometimes, just having them come in, maybe they feel more comfortable with that person. Nothing against you or how you're handling things, but maybe they know the other Cena better. Maybe they've dealt with that Cena's dealt with them before and they have any tips or tricks. So sometimes just even asking other Cenas, the nurse, do you have any tips or tricks on Mrs. Smith? I'm having a hard time. And people that have worked with her before might know how to help, um, get her to cooperate a little bit better with care. Now, if you've tried all these things, you've done everything that you can think of, incentives, anything that you can think of. So try to be creative. Oh, bingo's at 2 o'clock today. If we get this done, you'll be out in time for bingo and you'll be ready to go. Little things. So if bingo is something that motivates them, then you could use that, or whatever else is going on in the facility, you could use that to assist them as well. Now, all of that fails. You've done everything you can imagine and think of to try to get them to cooperate with care. What you then can do is you're going to let the nurse know. So go to the nurse, let them know, listen, I've tried everything. I can't. I've tried a minimum of 3 times. They're not cooperating. I can't get them to to take their shower, for example, the example we've been using. Then you are also going to document it. So you are going to also chart that they refuse care after you've attempted 3 times to provide that care. Now, this is sort of a twofold thing. The reason why we not only tell the nurse, but we also document it is for a variety of reasons. One, we want to make sure that you're documenting everything that you do to protect yourself and the facility. Secondly, doctors and nurses and other care team members are going to use that chart to get a big picture of the patient. Not only are they looking at medications and lab values and vital signs, they're also going to look at behaviors and things like cooperating with care and things of that nature. So when they look at this, maybe this is a small piece of the puzzle, and they're going to be able to get a better picture on something that might be going on with the patient. Secondly, sometimes this has happened to me a million times where I go in and I do everything I can think of, talk to the patient, try to get them to cooperate with care, to engage, and they just won't do it. And then the doctor will come in or the nurse, and without fail, the nurse comes in. And this happened when I was a CNA. So I would say, "Oh, Mrs. Smith, let's go take a shower." No, 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 no. Let the nurse know. The nurse walks in. "Hey, Mrs. Smith, today would be a really good day for a shower." "Oh, you think I should take a shower?" And next thing you know, Mrs. Smith is in the shower, all because the nurse told her. Sometimes if they perceive that person has authority, they're going to listen to them. And it doesn't matter how many times you tried or what you did, it just took somebody else. Happens to me all the time as a nurse. I'll tell a patient something that the doctor told us, but until the doctor physically tells them, they don't always believe us. So sometimes it's just that perceived authority that works as well. So, that's why there's multiple reasons why we not only document but report it to the nurse too, because maybe the nurse can help you out. Lastly, as always, be truthful and honest when you're documenting your care. Don't document something you haven't done. Don't document something you're about to do because you don't know exactly what that's going to look like, because people do refuse care. Things change constantly. You want to make sure everything's accurate and honest. Some other ways that you can protect residents' rights are if a patient has any questions or concerns or complaints, making sure you let the nurse know about any of those, making sure we're knocking and asking permission before we enter the room. Remember, that's their home. You're not going to walk into a stranger's home. You shouldn't without knocking. Same thing with our patient. We're not going to look through their mail or belongings or gossip about the residents. The gossiping I see a lot. If you pay attention, anytime you might have been in a nursing home or hospital, or if you've never been in one, when we go to clinical, the nurses station are typically in the center of the hall. That's where people tend to gather, and sometimes where people can start to gossip. And when you're gossiping in the center of the hall, family members, patients, visitors, strangers can hear exactly what you're saying. So you want to be extremely careful with that. Making sure if you're talking about care, remember HIPAA, making sure you're following HIPAA. Anytime you're talking, you're doing it in a private place, you're being careful with what you're saying and how you're saying it. Once again, do not accept any gifts or money from residents. Making sure you respect residents' personal possessions. So something may not look important to you, but that could be extremely important to our patient. So making sure we're handling everything with care, letting them know if we're moving things, where we're moving it, asking permission to move things. Imagine if somebody just came into your house and started moving things around, started touching things, they were being rough or mishandling things. That would probably upset you. It's the same thing for our patients or our residents. If there's any disputes or anything going on, making sure you always report it to the nurse. And then Importantly, another important factor is maintaining boundaries and making sure you're maintaining a professional relationship with your patients. So, what does a professional relationship look like? One, a positive attitude is going to be extremely important to have a professional relationship. Making sure you're only doing what you've been trained to do, and you're staying within your scope of practice. Making sure you're keeping all the residents' information confidential. You're following HIPAA. You're not discussing your personal problems. This is sort of a big one. You do become close with your patients, and some people talk about their family and hobbies and likes and dislikes. But we really want to be careful of keeping any of our personal problems out of that professional relationship. Making sure you're actively listening to the residents. You're calling residents by their appropriate name. You never give or accept gifts. And making sure you always explain care prior to providing it and not using any profanity, okay? These are going to be important things in maintaining that healthy relationship or professional relationship. Now, a huge part of indirect care is communication. Communication is going to be key on so many different levels. Not only communicating with the patient, their family members, but also the care team and everyone involved. So when it comes to communication, there's two different types of communication, both verbal communication and nonverbal communication. So our verbal communication is what a lot of people know and think of. Speaking slowly, speaking clearly, using words that have the same meaning, communication or communicating in a way that is facilitating and showing dignity and respect of our patients, making sure you have a good attitude. So all of these are going to be really important parts of communication. But the part that a lot of people forget about is this nonverbal communication. All right. Uh, have you ever been talking with somebody and they're saying one thing, but their body and everything else, all their nonverbals, are saying something completely different? And what they didn't realize is that their words were not matching their verbal communication was not matching their nonverbal communication. So it's important for us to notice eye contact. What is our body saying as we're speaking? What is our tone saying? What about our facial expression? What gestures are we using? Are we using the use of touch? So just making sure we're aware of not only our verbal communication, but also our nonverbal communication. Most people are affected more, even I would say so, by the nonverbal communication, the way you present yourself, how you walk in a room, your body language, tone, facial expressions are going to be very, very key in how you present to the patients and how your communication is going to come off to patients and the care team. Anytime we're communicating with somebody, there's potential that communication barriers could exist. Um, and in the healthcare setting, even more so. Some of those barriers are going to be things like the resident doesn't hear you, or it may be difficult to understand. Maybe the words are not being understood, or we're using slang or profanity, or even cliches. We're asking yes or no questions instead of open ended questions. When we ask open ended questions, we typically are going to get more information from them. They're going to have to speak more than answering than one worded answers. Um, it also gives us a better idea of how much or how well they are understanding what we are communicating to them. Another huge barrier is if a resident speaks a different language. That can be extremely difficult, especially in places like facilities like long term care or smaller facilities that don't have interpreters or translators on hand like a lot of hospitals do. Um, hopefully you have somebody in the facility that speaks that language, but that's not always the case. And then we never want to assume the resident understands us. That's why we ask open ended questions. Um, have them repeat things back to us is the best way to um, get an idea of whether they understand us or not. There can also be medical communication barriers, such as aphasia, which is going to be the impairment of language. And what it does is affects the production of comprehension of speech and the ability to read or write. And this can be from very mild to very severe. There is also dysarthria, and this is a motor speech disorder. And this is a condition in which the muscles that we use to speak become weak and we have difficulty controlling them. This could lead to slow or slurred speech that is difficult to understand. Now, there are going to be times that we have to communicate people with different impairments. So, the first one we're going to talk about is a patient or resident that has a visual impairment. All right. So, maybe they're legally blind, maybe they just have glasses. So, first and foremost, if somebody has a visual impairment and they do have glasses or contacts, we want to make sure that they're in or they're on them, right? I know it seems simple, but sometimes we forget the most simple things. So, making sure their glasses are on or if they have contacts, they are being worn. We always want to make sure we identify ourselves. We don't want to assume the resident or patient will know us by our voice. So always still always identify yourself. We're going to make sure we want to speak naturally and clearly. We want to make sure also, this is going to be especially important with a visually impaired, that we do not move personal items or furniture around. And when we're speaking to them about where things may be or explaining positions, we want to make sure we want to use like an imaginary clock to guide or explain position to the resident. So, for example, if there's something directly in front of them, and we're trying to explain that position at 12 o'clock, so they know, on the clock, the 12 o'clock is directly in front. If something is directly to the right, we could say 3 o'clock. If something was directly behind them, we could say 6 o'clock. If something was directly to the left of them, we could say 9 o'clock. So that gives you sort of an example of meaning the use of an imaginary clock to guide or explain position. We want to make sure we orient the resident to new areas, especially those that are legally blind. Um, we don't want to move furniture or things around because they get to know the space and the area, and they get to know how to walk safely around the items and where they're at. And if we begin to move things, it can cause falls and other hazards. So if we do introduce them to a new environment, a new area, it's going to be important that we guide them around, we let them know where things are, and let them know where they're at. Always make sure there's proper lighting. When we're talking to the resident, making sure that we face them. We want to still continue to use body language. They still may be able to see our shadow and what we're doing as far as our body is concerned. We want to use everyday language. We don't need to avoid the words like see or look. Make sure we name the person when introducing yourself, or when directing the conversation to them. So don't say you because they might not be able to see who you're looking at or who you're speaking to. So make sure you're using names. Do not channel conversations through a third person. So we're not going to talk through somebody else to them. We're going to talk directly to them. That's part of that dignity and respect. Make sure we're using specific language. Um, this is a big one. So what I always tell people is, if I were to have you close your eyes and allow me to guide you in a new space that you've never been, would you fully trust me? Probably not, right? You would probably hesitate with every step, being concerned about what was there if you were going to fall or run into anything. So, the more that we communicate, being as specific as possible when we're walking or ambulating and assisting our patients with movement that have visual impairments, is going to be extremely important. I always try to allow them to, if possible, um, with your right hand, you're going to feel the bed. Two more steps, and we're going to be at the end of the bed. You can feel the foot of the foot of the bed with your right hand. The door is on your left. You can feel the door. Letting them know where they're at, allowing them to feel if they're able to, but being very specific when guiding them, so we're not creating hesitancy, which will create a less likely chance to fall. So be very specific and almost over communicate, especially when moving them. If we're When it comes to the door, making sure it's either all the way closed or all the way open so they don't run into it. Um, Whenever we're assisting somebody to walk that has a visual impairment, um, if they're blind, We want to walk slightly ahead, letting the resident grasp your arm. So you are sort of guiding them. They know they're safe as well. We might need to give them assistance with cutting food and opening containers as needed, showing them where their food is and what part of the plate each portion of their food is on. If they do have a guide dog, we want to make sure we do not play with them. The guide dogs are there to assist them, not to play. If you want to pet, always ask permission. Encourage the use of other senses as well, and avoid competing noise. Obviously, we're heavily relying on communicating verbally with them since they're unable to see or have some type of visual impairment. We want to make sure that we cut out any radios or TVs or anything else going on if possible. That way they can fully hear us. When it comes to somebody with a hearing impairment, we're going to have some of these same things that we were just talking about with visual impairment, but there's going to be some other things that we should be well aware of as well. We want to make sure we get the residents' attention before we start speaking, making sure if they do have any hearing aids that they're not only in their ears, but they're also on and working. Making sure we maintain eye level communication. So we're facing them directly, making sure we're not covering our mouth, um, making sure that we're speaking clearly and slowly without shouting or exaggerating our mouth movements, making sure, once again, we're stating the name before we begin a conversation. We can lower the pitch of our voice. We want to speak to the side with better hearing. So some people might have poor hearing on one side and better hearing on the other. So if they have better hearing in one ear, making sure we're speaking on the side that has better hearing. If they can't hear us, they're not understanding, maybe repeating what we said or using different words if necessary. Um, there are going to be times where we can use visual charts or picture cards or notepads where maybe they can write down what they want. I've used dry erase boards or notepads before. If they are unable to write, then what we could do is get the visual chart. And basically, what it does is it has pictures on it. We call these communication boards as well. And it can have a picture of like bathroom, um, food, pain, book. Some of these like basic needs or anything that might be common for that specific patient. And that way, if they need to communicate, they can point directly to the picture, which can help us figure out what they need. We want to make sure we're being patient and empathetic and understanding. Ask the resident to repeat what was said when necessary and observe their body language as well. Like I mentioned, keep hands away from the face, avoid chewing gum, making sure you're using short sentences and simple words, and really, really try to avoid jumping from topic to topic because that can be confusing and difficult for them to follow, especially if they're reading lips, and are having a difficult time hearing. Just like before, always try to minimize any extra noises, try not to compete with them, turn down the radio, the TV, anything of that nature. Communicating with a cognitively impaired resident, um, this one's a little bit harder to really talk about in regard to um, there can be very high functioning and very low functioning when it comes to cognitive impairment. So I always walk in treating every patient the same until maybe I see that they're not understanding or they're struggling with how I'm communicating with them, and then I may need to adjust. So, depending on the level of function, you may or may not need to adjust how you care for somebody with a cognitive impairment. In fact, you probably know several people with different cognitive impairments, and you would never know that that exists within them. So, if possible, include family and friends when a resident is not able to understand what you're trying to say. They may be able to have better ideas and tips and strategies on what works best for them. Do not talk to adults as if they were children. Like I always said, we're always treating them with respect and dignity. Be sure that what you say and how you say it is showing respect and concern. Sit or stand at a normal distance from the resident. Be aware of your body language as always. The people that know them best always ask for advice and what the best way to communicate with them are. Speak in a plain way using simple words. If possible, speak with a place with fewer distractions. Discuss one topic at a time, ask one question at a time, and then wait for an answer before asking another. Repeat the question or message as often as needed. If you're able to use real objects and examples and able to show them instead of just telling them, that may be a little bit more beneficial. And asking yes or no questions is actually more beneficial with those with cognitive impairments than open ended questions, once again, depending on their level of functioning and understanding. Now, unfortunately, the healthcare field is not always rainbows and butterflies. We do at times have to deal with patients that become angry or combative at times. So, what do we do when this happens? Because our communication is going to play a key role in how we de escalate or escalate the situation. So, number one thing is always stay calm. Do not argue or respond to any verbal attacks. Stay calm yourself. Important though, do not tell them to stay calm. If you've ever been in an argument with anybody and somebody's told you to calm down, that probably did not yield the reaction that they wanted, because usually that escalates people. Um, Try to empathize with the resident or the patient. Try to understand, what they're feeling, why they're feeling it. Try to find that trigger. What caused them to be angry? Make sure you're using active listening. Allow them to speak, listen to what they're saying, and respond to what they're saying. So when you listen actively, make sure you're being attentive. You're making eye contact, nodding, making sure they know you're hearing what they're saying. Making sure you continue to treat the resident or patient with dignity and respect. You know, Once you find that cause, once you listen to them, let them know what you're going to do and how you're going to fix it, or if there's something that you can do or follow up with. So you may not be able to fix some of their problems, but most times I find patients, when they're angry, they just want to be heard. Um, you know, you just sitting there and listening to them is going to make a huge difference. And then when you find out why they're upset, if it's something that you can't fix, let them know you'll follow up with somebody that might be able to fix that problem. And then make sure you're explaining to them how you're going to follow up and when you're going to do it. That way, that builds that trust and will continue to help de escalate them. Um, Answer call lights promptly. This is a huge thing why a lot of people get angry. Unfortunately, you are only one person and you can only be in one place at once, and you have several patients to take care of. But answer as quickly as you can, and this will help sort of decrease some of that anger, or that buildup of anger at least. And as always, when somebody's angry, they have, even though they're only verbally angry here, they have the potential to become combative. So you always want to stay a safe distance from the resident, just in case to become combative. And you always want to make sure your back is to the exit. So, meaning that if they were to become combative, you do not have to go by them or through them in order to get to the door. So I always make sure I have an easy way to exit the room, just in case somebody does be combative. You also may want to make sure, I keep something between me and the patient, meaning the bed, a chair, a table. That way, if they try to become combative at all, that you are in a safe place. There's something between you and them that can prevent them from potentially hurting you or attempting to hurt you. Um, so, safe distance, make sure there's always an exit available in the room for you are going to be important, just in case it does escalate. But if you are communicating effectively, hopefully you can de escalate the situation. There's also one thing I want to add is that sometimes just your presence alone can escalate the situation. So if our patient is angry and it's clear that you've tried to listen, you've stayed calm, you've tried to help them and it's not working, sometimes excusing yourself from the room, as long as they're in a safe position and they are being safe, is the best thing you can do, and that alone will de-escalate the situation. What if our patient becomes combative? Unfortunately, this does happen at times, and this is why we want to have good communication skills. So hopefully, we can prevent this from happening. But unfortunately, there's times where it doesn't matter how great your communication skills are, um, some things are out of our control. So What we want to do is make sure, once again, we're staying calm, we're lowering the tone of our voice. We allow the resident time to calm down before our next interaction. We want to make sure we ensure the resident is safe and we give them space. Um, so once again, we're keeping ourselves safe as well. So we're not only giving the patient space, but we're giving ourselves a safe distance away from them. I always say, I know this says arm's length. I always say, like to say length, a leg length away. Um, a little bit further than arms is always a little bit better. Um, we always want to remain calm, be flexible with the patient. Talk to them, stay neutral. Do not argue, accuse them of wrongdoing. Once again, actively listening is going to be important. Make sure you're not using any gestures that could frighten the resident. Be supportive. Consider and think about what provoked them. Are you what's provoking them now just by being present? Obviously, any inappropriate behavior to the nurse, make sure you're letting them know. Never, ever, ever hit back. If they're trying to hit you, block blows and step out of the way and immediately try to leave the room as long as they're in a safe position and place. Obviously, once again, allow the resident time to calm down before the next interaction. Most importantly, your safety is also important. Um, you know, but we have to make sure our patient's safe. If you have somebody who's not being safe, obviously yell out for help. But sort of look at the situation, what you can do to make it safe, and what you can do to make sure yourself is safe. Always make sure you have an exit to the door, like we talked about in the previous slide as well. Now, once again, you are going to be working with patients from all different walks of life, different cultures, religions, socioeconomic backgrounds, and so on. So it's important that we learn that um, with different cultures and different things like this, people are going to have different beliefs, different behaviors, different values and attitudes. Um, so, as a nursing assistant, you should focus on compassionate, respectful, and culturally sensitive care, making sure you treat your residents as residents wish to be treated. Treat them like they're your own family member. Culture, age, family, background, and customs are going to completely shape each person's way of thinking. So ask questions to find out what is appropriate and to always respect their choices, beliefs, and behaviors. It's not our job to judge those, right? We're there to respect them and provide the best care that we can based on their needs and wishes. So, once again, each culture may have different knowledge, behaviors, beliefs, values, attitudes, religions, and customs. So, making sure we're listening and observing carefully will help give us a better understanding of their needs and feelings. For example, in some cultures, touching can be seen as threatening and harassing, whereas some cultures, touching can be seen as like an act of caring, like placing your hand on their shoulder. A hug can be an act of caring. Eye contact can be seen as disrespectful in some cultures, or in a lot of cultures, eye contact can be seen as a sign of respect. So, this is why we have to sort of get to know these different cultures and religions and an idea of what the belief system is within them. These are some examples of many different cultures that do exist, and there's plenty more than this. This is just an idea of what some of those are. There's many different religious differences, so you can see here. There's a long list of some, and there's plenty more beyond this. This is just a general, quick list just to see that there are differences in religion as well. Now, within culture and religion, we have to realize that there's going to be there's going to be a lot of different viewpoints within each culture and religion. Some may be very strict with their cultural or religious views. Some may only follow certain parts of it. Um, so it all depends on the person. So it's just that's why we need to ask and talk to our patients. So for this, you will have a culture diversity paper. So what I want you to do for this paper is you're going to pick either one culture or religion. You don't need to pick one of each, just one total. So a culture or a religion. And then what you're going to do is you're going to do some research on that culture or religion to find about some of this, to answer some of these questions below. So you're going to write a one-page paper answering the following questions. What are the beliefs of your particular culture or religion as far as medical care is concerned? So, do they believe in holistic approach? Do they refuse any blood transfusions or any specific or certain procedures? What do they feel about life support or code statuses like DNR, do not resuscitate, or full code? Um, what about medications? What do they think about those? Same sex caregivers. So, a general idea of what your culture or religion's beliefs are when it comes to medical care specifically. Then, what are the beliefs about death and dying process? Do they want somebody caring for them? Are there certain items that should be around them or near them? What do they believe about after death, autopsies, specific items or procedures after death, and funerals that should be present? Are there any cultural or religious norms, such as eye contact, or, being disrespectful, or the touching, like the examples that I just gave you in the previous slide? All right. So once again, this is a one-page paper answering the following questions on this screen. Just make sure um, they are answering all the questions and you're picking either a culture or a religion. It's anyone that you want. I always encourage you to pick one that is not your specific culture or religion. It's always good to learn about other cultures and religions and what their beliefs are. So if you come across a patient that is of a different culture or religion, you will have a good idea about what that looks like. Now, infection control is a huge part of our indirect care. Obviously, it is extremely important to keep our patients safe, as most of them are going to be immune compromised. So, making sure we're doing the things we can to stop the spread of infection. So, infection control is going to be a set of standards that are put into place to help stop that spread of infection. And the best way to stop the spread of infection is through hand washing. Also, through following universal and standard precautions, which we're going to jump into what those are here in just a minute. So, the first one we're going to talk about is universal precautions. Universal precautions is an approach to infection control. And to sort of sum up this whole slide here, is that we are assuming every single patient we come into contact with has an infectious disease. All right, so we are assuming that they have an infectious disease. Because in real life, everybody looks the same. We can't assume somebody does or doesn't have an infectious disease. So we always have to protect ourselves, assuming they have it. Also, having an infectious disease can be hard for some people, and admitting it can be difficult. People are afraid they're going to be judged. And so they don't tell us they have one, and we don't always test for these right away. So that's why we're always going to assume they have an infectious disease. Within universal precautions, we have what we call standard precautions. Now, standard precautions are going to include things like refraining from touching the resident before our hands are clean. So, every time we enter the room, the very first thing we're going to do is wash our hands before we touch our patient. Every time we leave the room, the very last thing we're going to do is wash our hands. So, we always leave with clean hands. We are always going to wear gloves when we come into contact with bodily fluids. Now, bodily fluids are going to consist of things like blood, urine, saliva, sputum, drainage, feces, semen, vaginal secretions, vomit, broken skin, or any mucous membranes. Now, mucous membranes are things like the nose, the mouth, things of that nature. Now, as soon as we're finished with bodily fluids, we want to make sure we remove our gloves immediately as soon as we're done with that procedure. We don't want to walk around after we've touched bodily fluids and touch everything in the room. So that's why we remove them as soon as we're finished with the procedure and any bodily fluids. Anytime we remove our gloves, we immediately wash our hands. So remove gloves, wash hands. If our any of our skin surfaces ever become contaminated with any bodily fluids, we want to make sure we immediately stop what we're doing and wash all skin surfaces that have been contaminated. Now, you won't be working with needles as a SENA typically. But it is important to know that you should never recap any needles or sharps after you're done using it. And most importantly for you as a CNA, you're going to be in the room with patients who are, or excuse me, with other care team members like nurses, doctors, and so on that might have needles out. They might be drawing blood, putting in an IV, performing a procedure. You need to be aware of where these people are and where the sharps or needles are. That way, you're not running into anybody, getting accidentally poked yourself, or hurting somebody else. You also want to make sure that anytime you're shaving a resident, that you're avoiding any nicks or cuts. So you're not going direct shaving directly over any previous nicks or cuts they may have. Any contaminated supplies should be carefully bagged. If you ever collect any bodily fluids for a specimen collection, you always want to make sure that you label it correctly. Now, when we label things that are specimen that we collect, what should go on that label should be the name of the patient or resident, their date of birth, their room number, and then making sure the date and a biohazard label is on it. It should also have the time it was collected and the initials of the person that did collect it. Making sure we keep them in the container with a lid on it and it's in a biohazard bag so people know that this is bodily fluids. It's a biohazard specimen bag anytime we're transporting it. Obviously, we also want to make sure we're disposing of all contaminated waste according to your facility's policy. Now, when it comes to washing hands, there's 4 rules that we use for you guys to follow. So if you can remember these 4 rules, this should answer most of your questions in regard to when to wash your hands. So every time you enter the patient's room before you touch the patient, you must wash your hands. Immediately after you take off your gloves, you must wash your hands. The very last thing you do when you leave the room is before you leave the room, excuse me. So the very last thing before you leave the room is wash your hands. And anytime bodily fluids touch your skin, stop what you're doing, wash the skin that it touched and your hands. So those are our 4 hand washing rules. So always try to remember those 4 rules. So hand washing is a skill on the state exam along with indirect care. All right. So hand washing, as far as what this is going to look like, is you're going to need a few supplies. Obviously, you're going to need a sink, then you're going to need soap, paper towels, and then a waste paper basket to throw them in. Now, as part of the class, you get that purple folder, and that purple folder is going to have the skills checklist guide in it. And in that checklist guide, the heart to heart and prometric, I want you to read through hand washing. All right, this is going to give a step by step process and exactly what that looks like. And there'll also be an additional video for you to watch within this lesson or on our YouTube channel that you can see exactly how to properly wash your hands, not only for the state exam, but to help prevent the spread of infection. So anytime you wash your hands, you should wash your hands for a minimum of 20 seconds, all right? So a minimum of 20 seconds. You could sing the ABCs or the happy birthday song. I always tell people to make sure you're doing it for the correct amount of time. A watch or looking at the clock is always going to be best practice. You always want to use liquid soap instead of bar soap. Bar soap tends to harbor bacteria, so liquid soap would be your best option. When you're washing your hands, your elbows should be over the sink with your hands pointing down. Whenever you wash your hands, you want to make sure you're using friction. This is going to really help with the bacteria and removing microorganisms. A big place that people forget is we want to remember to wash around our cuticles. This is where most microorganisms tend to stick. Making sure we're washing under our fingernails and between our fingers as well. It's important to note that chipped nail polish traps and catches more microorganisms and contributes to the spread of germs and requires additional friction during hand washing. Fake nails or long nails can spread germs more easily and trap microorganisms that are not easily removed. So a lot of healthcare employers do not allow them. Do not forget to wash your thumb and little finger and the side of the hands. I find that this is an easily forgotten area as well. We want to make sure we fully rinse the soap off all our hands and completely dry from fingertips to wrist. Whenever we go to turn off the water, we should be using a dry piece of paper towel. So, only a dry piece of paper towel to turn off the faucet. The faucet is one of the dirtiest places, harbors so much bacteria and microorganisms. So, I want to use dry paper towel. If we use wet paper towel, microorganisms and bacteria can travel through the moisture. That's why we use a dry one. So, whenever water is available, especially in long term care settings, please be sure to use um, the hand washing technique that we just talked about and the video that is also on this lesson plan following it strictly that way. However, if water and soap is not available, then hand sanitizer can be used. Um, Once again, though, in long term care setting, hand sanitizer typically is not a substitution for hand washing with soap and water. If water and soap is available, you must use that in long term care. However, in the hospital, you'll notice we sanitize in and we sanitize out. So we're using the hand sanitizer a lot more. Anytime we're putting hand sanitizer, we want to spread it around the front and back of hands, including between fingers, making sure we're rubbing the product until the hands are completely dry. This should be a minimum of 15 to 20 seconds. Now we're going to be talking about how we put on gloves properly and the rules for putting on gloves. So, once again, gloves must be worn anytime you may touch bodily fluids or broken skin. We should wait to put on gloves until right before we're going to touch those bodily fluids. What I see a lot of students wanting to do is the second they walk in the room, they want to put their gloves on. But you should wait until you're actually going to be touching bodily fluids. So, basically, the first thing you should touch after putting on the gloves is the patient. Soon as we're finished with bodily fluids, you need to remove the gloves. So, typically speaking, exit protocol should never be done with gloves on. We'll get into what exit protocol is here further on throughout this PowerPoint. But as soon as you're done with bodily fluids, take the gloves off. As soon as the gloves are taken off, the very next step should be washing your hands. So, immediately wash hands after removing gloves. So when we go to to put our gloves on, you want to make sure you wash your hands first. You're going to slide one glove on your hand. Using your gloved hand, slide the other hand into the second glove. You then interlace your finger to smooth out folds and create a comfortable fit. And then you carefully want to look for any tears, holes, or discolored spots. Obviously, the goal of the gloves is to prevent any bodily fluids from getting on our hands. So, if there's any tears or holes, or if it's a discolored spot, that most likely means that it will rip or tear easily. We want to take off those gloves and put new gloves on. If we're wearing a gown, which we'll get into that here shortly, we want to pull the cuff of the gloves over the sleeves of the gown. What's really important is when we go to remove our gloves. Removing our gloves, remember our gloves are the dirtiest thing. We've been touching bodily fluids. We want to make sure when we go to take these off, we're taking them off in a way that does not contaminate ourselves. This is going to be extremely important on the state exam and in real life. This is a huge way that infection is spread by people not removing their gloves properly. So we're going to do this by only touching the outside of one glove. With one gloved hand, what you're going to do is you're going to grasp the other glove at the palm and pull the glove off. So grasping it at the palm, and I have a picture that you'll see in the next slide, and there will be another video posted in this lesson that shows you how to properly remove them. Now, you're going to ball up that glove that you just took off in your remaining gloved hand. And with the fingertips of your gloved hand, hold the glove you just removed. With your ungloved hand, slip two fingers underneath the cuff of the remaining glove at the wrist, making sure you do not touch part of the outside of the glove. Then you're going to basically take this glove, pulling it inside out as you're pulling it off, and then you should be holding only the inside portion of the glove, that the clean side, I guess you could call it. And then you're going to throw the gloves away and immediately wash your hands. So to give you a better idea, I'm going to show you the picture, and once again watch that video that's in this lesson about how to remove the gloves. So here you can see a picture. So in the very top left corner, you'll notice that with one gloved hand, they're pitching the bottom palm. So their glove isn't touching their skin, it is touching the glove. They're pulling it inside out, balling it up as we move across to the third picture in the gloved hand. In the bottom left picture, you'll notice they're taking 1 to 2 fingers, placing it underneath the glove. So they're on the inside only, they're not touching the outside of the glove. They're pulling it inside out, and then they're going to be tossing it. So hopefully this gives you a little bit better of idea. And like I said, please watch that video as well. Personal protective equipment, or what we call PPE, is something that you will be using a lot in the healthcare field. So PPE, once again, stands for personal protective equipment. And we're going to wear this anytime that there could be potential splashing or spraying of bodily fluids. Or if somebody has a infectious disease or illness, or is put on isolation and or precautions. So what personal protective equipment can include are things like gloves, gowns, goggles, and mask. So how we put this on is gown, mask, goggles, gloves, but most importantly, how we take it off. All right. Our PPE, when we take it off, we want to make sure that we do not contaminate ourselves. So our dirtiest part is what's going to come off first, which is the gloves. So if you notice on this order on how to remove PPE, it's in alphabetical order. All right, so gloves comes off first, then our goggles, then our gown, then our mask, and then we wash hands. So this is the correct order on how to remove PPE. Now, there are different types of isolation precautions. And once again, people will go on isolation precautions due to different things, like if you've heard of MRSA or C. diff or the flu or SARS or the coronavirus. So it's really important that when people are on isolation or precautions, this means whatever they have can easily be spread, and we want to make sure we're taking extra precautions to protect ourselves and our patients. So the first one we're going to talk about is contact. And when somebody is on contact precautions, these patients have some type of infection that can be spread by contact with a person's skin, their mucous membranes, feces, vomit, urine, wound drainage, or other bodily fluids. Most commonly, MRSA or MRSA and C. diff are going to be found under contact precautions. When somebody is on contact precautions, we need to wear a gown and gloves. So we only need gown and gloves for contact precautions. The next kind is what we call droplet precautions. Now, these type of patients have an infection that can be spread through close respiratory or mucous membrane contact with any type of respiratory secretions. So this can be things like influenza, pertussis, meningitis, or rhinovirus. What people are going to need for this are gown, gloves, and mask. So gown, gloves, and mask for droplet precautions. The next kind that we're going to talk about is airborne. Now, this is when a patient has an infection that can be spread over long distances, and it can be suspended in the air. So these diseases are the particles are very small and require special respiratory protection and room ventilation. So these are things like SARS, TB would be major examples. What you're going to need is a gown, gloves, and mask. And this is going to be a specialized mask, like an N95 is a great example of one of the specialized masks that exist. So this is typically going to be seen in your hospital setting, but gown, gloves, and that specialized mask are going to be extremely important. Now, they do have other types of isolation precaution, what we call neutropenic or reverse, which is when the patient, especially those that maybe are receiving chemotherapy, they're immune compromised. And what we're doing is we are gowning up. So we're going to put a gown, gloves, mask on. to protect our patient that we're not getting them sick. So we're not bringing anything in their room as an extra precaution because they are immune compromised. Their immune system is deficient. It's not able to fight off things as much as a healthy individual would be able to. Now, when somebody's on isolation precaution, there's a specific way that we need to enter the room and leave the room, and how we put on our PPE equipment and how we take it off. So, when entering a room with a patient that is on precautions, it's going to be extremely important to note that typically what we find is on the door there will be a laminated piece of paper, and it usually has a stop sign on it, and it says "See nurse before entering." That's a huge indication that this person is most likely on isolation precautions, and we need to talk to the nurse before we go in if the nurse hasn't already talked to us. It's also important, though, that every facility is a little bit different on how they identify these patients. So you want to make sure you're familiar with exactly how your facility identifies patients that are on isolation or precautions. Anytime somebody's on isolation or precautions, there's typically either a cart right outside the door that has all the PPE equipment on it, or there might be a door caddy. So, sort of like a storage device that hangs over the door that will include all your PPE equipment. This is another good indicator that that's there for a reason. And if you see that outside a patient's room, you should most definitely double check with the nurse before entering. Checking the care plan would be another important task. Now, PPE equipment should be donned or put on in the hallway prior to entering the room. So you don't walk in the room without the PPE equipment already on. So you put that PPE equipment on in the hallway and then you enter the room. When you enter the room, um, you're going to complete whatever tasks you need to. And then at the exit of the door, there should be a extra trash and linen hamper. And all your PP equipment must be removed at the door before you enter into the hallway. So you're going to take off your PP equipment in the proper order at the door before entering into the hallway. You're going to be washing your hands and then exit, making sure not to touch anything on the way out. This is something that I see students do make mistakes on often. One, I constantly make catching students in the hallway with gloves on. If your gloves are on in the hallway, that means you didn't wash your hands when you exited the room, or you didn't wash your hands properly when you entered the room. If you walk out into the hallway with PPE equipment on from a patient that has an infection, you now just brought all of that microorganisms, those bacteria, that infection into the hallway, into a public area, and that is exactly how infection can spread. So it's very important to understand that you put PPE equipment on before entering the room, and you do not walk into the hallway with PPE equipment on from the room. You take it off in the room, wash your hands, and exit. Our immune system is basically our body's defense system. So its whole goal is to try to keep us healthy, to prevent infection, to fight off infection. So it does this by attacking organisms and substances that invade our body and cause disease. So with infection, there's two types of infection: localized and systemic. A localized infection is something that you guys have all probably had at some point in time. It's an infection that is limited to a specific location in the body. You fall and scrape your knee, you cut your finger. Some signs and symptoms of a localized infection are going to be things like painful to the touch. You'll notice that it's red, it's swollen, it has pus or drainage coming out, and it's hot to the touch. All right, or has heat radiating off of it. So that's a sign of a localized infection. So once again, if you've ever cut your finger, fall and scrape your knee, and it became infected, you probably had a lot of those same symptoms. Now, a systemic infection is something that affects the entire body. And some signs and symptoms of a systemic infection would be things like fever, body aches, chills, nausea, vomiting, weakness, headache, mental confusion, and a drop in a person's normal blood pressure. So, an example of a systemic infection would be something like sepsis or somebody going septic. Now, infection can spread in a variety of ways through hands, blood, food, fluids, dressings, um, contaminated equipment and utensils, insects, and animals. So, when I say dressings, I mean like wound dressings, like bandages. All right, so these are all the different ways that infection can spread. Now, there's different ways that it can enter our body and exit our body. As far as portals of entry when it comes to infection, we can inhale, so respiratory. Gastrointestinal would be like ingesting, so eating or drinking. Blood or breaks in the skin. As far as how it can exit our body, are very similar. Respiratory, so airborne droplets, so by us coughing or sneezing, it can exit our body through blood or through wound drainage. These are all ways that infection can spread, either entering our body or exiting our body. So the two most common types of infection that you most likely are going to see in any type of facility is most likely going to be MRSA and C. diff. Once again, these are contact precautions, and as a reminder for contact precautions, we wear a gown and gloves. So what's needed for growth of an infection or bacteria? So first we need a host, right? So that has to be present. Then moisture, warmth, darkness, nourishment, and oxygen. So it's really important that if we can take something away, that we do. So moisture is the biggest thing that we can control. So that's why you're going to hear me talk a lot throughout this class about leaving the body clean and dry. If we can take away some of that moisture, hopefully we can get rid of some of the requirements that are needed for growth when it comes to bacteria and infection. Now, what we have to remember is not only are elderly susceptible to infection, but anybody that's sick or currently healing from anything going on. So, really, any of our patients in our facilities are going to be susceptible to infection for a variety of reasons. Now, obviously, our elderly are going to be a little bit more immune compromised because the aging process, right? As their immune system's been fighting for a long time, and with that being said, it tends to, not be able to fight off things as well as it used to because of that aging process. There are certain common problems that can dispose residents to infections, such as chronic illnesses. And then the other three are things you're going to see in almost every patient. Typically, when we're sick, we don't drink as much fluid as we should. We don't have the best nutrition, and we're stressed out and we're tired. So, poor nutrition, dehydration, and stress and fatigue play a major role in our immune system. This is why, if you notice, a lot of college students tend to get sick around finals time because they become extremely stressed. They're not getting enough sleep, and a lot of times poor nutrition and dehydration play a major role in this as well. But this is going to be true in a lot of our patients. So we have to be extra cautious with our infection control standards, making sure we're following universal precautions, making sure we're following standard precautions, doing everything we can to prevent the spread of infection because most of our patients are going to have compromised immune systems due to their current illness, chronic diseases, and some of these other items that are listed here on the slide that we spoke about. So preventing infection again is one of going to be our major roles as part of the care team. So infection prevention is going to be the set of methods practiced in healthcare facilities to prevent and control the spread of a disease. This means following standard precautions, um, always treating blood and bodily fluids and non-intact skin as if they were infected, and we're going to be using standard precautions on every single patient. Hand washing is going to be the best thing that we can do. So, always washing our hands, washing them properly, using hand sanitizer when needed, following those universal precautions. If somebody's on isolation or precautions, we are going to continue to make sure we're wearing the proper PPE when working with that patient, making sure we're chemically disinfecting all of our equipment and cleaning our equipment as often as needed, and following your policies and procedures at your facility. Making sure that we're handling our equipment, linen, food, waste products, bodily fluids the way that we should be, making sure everything's properly labeled, it's being cleaned, it's being disinfected, that we're, food's being served at the proper temperature. And then if we have an employee that's ill or infected, making sure they're not caring for residents. You know, this is the hard parts. We need to be dependable, but when we're sick, we're having a fever, vomiting, diarrhea, things like that, we have to be careful and cautious to keep our patients safe because of their compromised immune system. Now, on the state exam, and anytime we're working with a patient, these are going to be some things when in regards to indirect care that they're going to be looking for specifically, and how we can make sure we're doing everything we can to hit these checkpoints. So, once again, when it comes to infection control and comfort guidelines, what we're looking for is we're making sure we're not touching. The very first thing we do when we come into the room is we're going to wash the hands. We're not touching the patient before our hands are clean. Making sure we end the skill with clean hands. So that's the very last thing we're going to do. We're going to wear gloves anytime we may encounter any bodily fluids or broken skin. We're going to remove gloves correctly. That way we're not contaminating ourselves. We're going to cover the overbed table with a barrier before we set any of our supplies down. Our supplies should never go directly on that overbed table without a barrier in place. That barrier can be something like a towel, a disposable pad, anything like that that lays over the table. Those tables tend to be very dirty, so we want to make sure that we have a barrier on any overbed table. We want to avoid holding any clean or dirty linen against our scrubs. So we should always keep linen away from our scrubs. This is something a lot of people struggle with because we all have bad habits at home. When we grab linen, we literally usually hug it right to our body. And so because we have that habit at home, we tend to translate that to work. And we need to be extremely cautious of this because our scrubs are considered dirty. So when we're grabbing clean linen, we don't want to be putting clean linen against us, and we want to avoid putting dirty linen against our scrubs too because we don't want to spread that infection. We want to make sure we avoid placing any linen directly on the floor. So all dirty linen should go directly into the hamper when you're done with it. We're never throwing it on the floor, always directly in the hamper. We should not shake linen or sheets. So when we get into learning how to make a occupied bed, you'll notice that I talk a lot about not shaking the sheets, not fluffing them. When you make your bed at home, a lot of times people take the sheets and they shake them out and throw them up in the air. And really what that's doing is that's spreading microorganisms and bacteria everywhere. And so we want to avoid doing that in the healthcare setting. You should never wear gloves when collecting clean linen, and we should always and only collect clean linen with clean hands, okay? So no gloves when collecting your linen because that means your hands are dirty and now you're touching other clean linen with dirty gloves, dirty hands. Always make sure you're asking about the resident's comfort with water temperatures. So remember, anytime water is involved in any of our skills or anytime we're taking care of a patient, we're going to ask them what temperature they prefer. You'll be surprised that everybody wants warm water when a bath. Some people like room temperature. Some people have different preferences. And some of that's due to other illnesses and diseases. Secondly, after we ask them that temperature and we go get the water, we're going to make sure we have them test the water and make sure it is comfortable for them. What is warm to us might not be warm to somebody else. So we want to make sure they're comfortable with the temperature that we got them. And then, as always, throughout every skill, every time we're working with a patient, we always want to make sure that we are asking about the resident's comfort. So not only about the temperature of water, but the position they're in, anything you're doing with them and adjusting them. You want to make sure you're always asking, how are you feeling? Is this comfortable for you? And always end the skill asking about comfort. Now, when it comes to indirect care, residents' rights guidelines are going to be important as well. So, how we can handle these is make sure we're announcing ourselves and knocking before we enter the room. Remember, this is their home. We have to knock before we enter, and we want to make sure they know who's entering their room. We're going to refrain from addressing the resident using terms other than their name. So we don't want to say sweetie or honey. So avoid calling them sweetie or honey, only by their name or what they prefer. Make sure we close the privacy curtain before providing care. So we're always giving them privacy. We want to make sure we leave them covered up to the shoulders as much as possible throughout the skill, making sure we always finish the skill with leaving them covered up to the shoulders as well. We want to make sure we're minimizing exposure of the resident while bathing or anytime we're moving covers around. Remember, always keep them covered as much as possible, only exposing the area that you are working with. Once again, never fully expose the resident, only uncover that area you are working with. Privacy is always going to be extremely important with our residents, part of that respect and dignity. Now, when it comes to indirect care, safety guidelines are extremely important. Remember, safety is always our number one priority. So, ways that we can make sure we're following these guidelines are going to be always leave the bed in low position at the end of the skill. This is to make sure if the resident tries to get up or get out of bed, or if they fall, that they're not falling from a high position, they're falling from a low position. The lower the position, the less likely for injury. So, once again, leave the bed in a low position at the end of the skill. Leave the call light in the resident's hand. That means the call light is what they use to get a hold of us. So that is what they use when they need us. They're in trouble. There's an emergency. They're going to hit that call light. So we need to make sure we leave it in the hand. Now you'll notice in some of your handouts it does say that we just have to leave it near their hand or on the bed within reach. But I always encourage that you put it directly in their hand. That way they know where it's at. If they move, it doesn't fall off the bed. It's always best practice. So I always encourage you to put it directly in their hand. When rolling or moving the patient, I am always going to encourage you to make sure that they are a safe distance from the edge of the bed. This is something that they're going to be looking at the state exam, and something you want to be cautious of in real life, making sure they're not too close to the edge of the bed, as if they are, what is most likely going to happen is they may end up falling out of bed. So always make sure they're a safe distance from the edge of the bed. Making sure anytime that you move the patient, you're transferring the patient or resident, that you are making sure the bed wheels, the wheels of the bed, the chairs, and everything else, or any other device that you're using, is locked when transferring them. When you're transferring or ambulating a resident, always make sure you're following the care plan for one, telling you, how many people it takes to transfer them, whether a gate belt's needed, whether a Hoyer, a lift, or any other thing like that may be needed. So following the care plan and making sure they have non-skid footwear on as well. So that can be things like shoes, socks with grips on them. Always making sure non-skid footwear and you're following the care plan correctly. When you're standing or adjusting position, making sure you're always asking if they're lightheaded or dizzy before continuing. We never want our patients to fall. So these simple questions, how are you doing after you stand them up or change their position, will help prevent that from happening. If there's any spills, we want to make sure we stop what we're doing and we clean those up immediately. That way nobody slips and falls on them. Now, the last point on here is how you roll patients when they cannot move themselves, all right? So in the state of Michigan, in the nursing homes, side rails are not allowed. So you will not see side rails on the bed in nursing homes specifically, all right? When there's not a side rail on the bed, what I encourage you to do is always roll the patient towards you, all right? This helps prevent them from falling off the bed. Unfortunately, I've seen it before where somebody rolls somebody away from them, and when they do so, a patient has fallen off of the bed because there was not a side rail or somebody else on the other side of the bed to prevent them from falling off the bed. So anytime you roll them, you'll roll the patient towards you. All right. If there is a side rail available or there's another person that is present, then you can roll them away from you because there is something or someone on the other side of the bed to prevent them from falling over. We will go over in details exactly how to roll somebody, the proper techniques, the proper way, and all that. But I just want you to definitely think and realize about the safety importance of rolling the patient towards you. So the last slide and the last thing to do with indirect care that we're going to talk about in this lesson is going to be our entry and exit protocol. Our entry protocol is how we are going to start every single skill. Every time we walk into a patient's room, these are the first 7 steps that you will always do. Our exit protocol, these will be the last 7 steps you do once you get ready to leave a patient's room. So as far as entry protocol is concerned, the very first thing we're going to do is we are going to knock. Remember, this is their home. We always have to knock before we enter. We're always going to make sure we greet them. We're going to make sure we're calling them by the name they prefer. And we're going to introduce ourselves, and we're going to let them know why we're there. So what are we there to do? Are we there to give them a bed bath? Are we there to take their vital signs, to check on them? So letting them know why we're coming into the room. We're then going to wash our hands. Remember, washing our hands is one of the very first things we're going to do, especially before we touch the patient. Then we need to check their ID. Now, we can check our ID in a variety of ways, but we have to make sure that this is the patient that we're supposed to be working on, that the care plan that we looked at before we walked in the room is the correct patient. So you can check ID one of many ways. The first way is, like they see in the hospital, is they will have a wristband on. That wristband will have their name and date of birth along with other information. So we can check that to verify the identity. However, in long-term care setting, most times we notice or you'll see that they do not wear wristbands that identify them. It's because if you think about it, this is their home. We don't wear wristbands around our home or IDs that identify who we are. So we try to make this as much of a home-like setting as we possibly can. So that's why you often don't see bracelets or identifiers on patients in long-term care. So we can do this a few different ways. One is the care plan or the chart typically has a picture of the patient in most nursing home settings, and we can look at the picture and then verify it by the patient. We can also ask the patient to tell us their name. So when you walk in, hi, it's Katie, I'm your Stina. Can you please let me know what your name is? John? Oh, hi, John. It's good to see you today. So that's another way that you could identify. The thing that you need to be cautious and aware of is that sometimes when we have patients that are have dementia, they have Alzheimer's, they're confused, Alzheimer's, all this can really affect their perception and what's going on. They might not be able to tell you who they are or their name, so we have to find these other ways to identify them. That can be through the care plan, if they do have an ID bracelet or anything along those lines on as well. So next, what we want to make sure we do is we want to pull the privacy curtain. Remember, we always have to provide privacy when we are giving care. Then you're going to need to gather any equipment you may need for whatever skill that you're going to be completing when you're in there. And then lastly, for entry protocol, you are going to raise the bed. When you raise the bed, what you want to do is typically raise it to about hip height. And what that does is that's going to help with your good body mechanics. Remember, you have to take care of yourself. If the bed's in a low position, you're going to constantly be bending down. That's going to hurt your back and cause issues down the road. So make sure you raise that bed for good body mechanics. So just sort of walk through it so you can sort of see what that looks like all together. Now, before I do that, I will tell you at the state exam, my recommendation and how I like you guys to practice it in lab when you practice your skills is to identify the patient with a wristband. It's sort of the easiest way to identify patients. It lets the nurse evaluator know you are physically checking their wrist. Sort of just makes it easier for them to check off. So the state exam, I recommend that. In real life, you'll have to go, depending on where you work in the facility and how they identify patients, will be how you have to follow it there. So I'm knocking. Hi, Mrs. Smith. I'm Katie. I'm your Sina for today. I'm here to take your vital signs. I'm just going to go ahead and wash my hands. Then I'm going to go ahead and check your ID. Can I just see your wrist bracelet? Perfect. Thank you, Mrs. Smith. I'm going to go ahead and pull this curtain so I can give you some privacy. I'm going to gather whatever equipment I need. And then lastly, Mrs. Smith, I'm just going to go ahead and raise your bed. I'm going to raise the bed to hip level. All right, so that would be an example of our entry protocol. Now we're going to complete whatever skill you're going to complete and move to exit protocol. So in regards to exit protocol, we're going to start by cleaning up. All right, it's always our job to leave our patient's area neat and clean. All right, that means all linen gets put in the hamper or taken to wherever it's needs to be disposed of, that all trash is in the trash, that all your supplies are put away, and the room is neat and clean. I always try to remind people, if I have a loved one in a facility or nursing home, a hospital, and I go visit them and I walk in the room and there's linen on the floor and there's trash that didn't make it in the trash can and there's supplies out and the place is not neat and clean, it gives me a bad perception that if they're not taking care of her room, how are they taking care of his or her as a person? Are they cleaning her up or him up? Or, so sometimes it gives a really bad perception in regards to that. So, always make sure, take pride in what you're doing and take pride. Remember, this is this person's home. We should always leave people's homes neat and clean if we got stuff out and moved it. So we expect the same here. We always want to make sure we're asking about comfort. Remember, that's a huge part of indirect care. So ask if the resident's comfortable, if they need anything else. Do they want a magazine? Do they want the TV or the radio on? A book, they want reading material. So see if they need anything else at all and make sure they're in a comfortable position. We want to make sure we put the call light directly in their hand. Remember, this is how they get a hold of you if there's an emergency or they need you. So make sure that call light's directly in the hand, and that is a huge safety point. So make sure that is there. Then we want to make sure their personal belongings are within reach. So in order to make sure they're within reach, what you'll notice is most times in the hospital nursing home setting, what you'll see is most people put their remote, their drink, their cell phone, any personal belongings, glasses, hearing aids, even dentures sometimes, they'll put on their overbed table. So we want to make sure that overbed table is within reach and they have everything that they want on that, or at least whatever they want within reach. So make sure you're always asking and putting everything within reach. What I find is if we don't put it within reach, what typically happens is, one, they call you right back, and so now your time management isn't very well. Secondly, they'll try to get up and get it themselves, which could lead to a fall or an injury. Then we're going to ask about their privacy curtain. Would they like their privacy curtain open or closed? All right, some people like to have that privacy curtain pulled. That way they have privacy, especially if they share the room with another individual. But we always want to give them choices and ask. We want to make sure their bed is in a low position. Remember, if they were to try to get up and walk or move, the higher they fall from, the more likely to have more injuries. So make sure the bed's in a low position. This is also another huge safety point. The very last thing we're going to do when we leave the room is we are going to wash our hands. We want to make sure when we enter the hallway, we have clean hands. We're not taking bacteria infection from the room we were just in out into the hallway. So that is why it is the very last thing we do. So to sort of sum up exit protocol and walk you through it, what I'm going to do is after I finish my skill, I'm going to make sure I clean up all my linens in the hamper, all my trash is in the trash, all my supplies have been put away. Everything is neat and clean. Mrs. Smith, are you comfortable? Perfect. Did you want a magazine? No? Do you want me to turn the TV on or the radio? Okay, perfect. I can do that for you. I'm going to give you your call light directly in your hand. I'm going to make sure your overbed table here, can you reach that okay? Perfect. Do you have everything you need on that? Great. I'm going to make sure your privacy curtain, do you want me to leave that pulled or push it back? I'll leave that pulled for you. I'm going to make sure your bed's in a nice and low position, Mrs. Smith, so I'm going to lower that down. I'm going to wash my hands, and now I can exit. So that is exactly what your exit protocol would look like. Once again, every single skill is going to start with entry protocol and end with exit protocol. We will definitely be practicing this a lot, so it's something you'll get used to in our laboratory section. It's something you'll be doing every single day. So, it might seem like a lot now, but overall you'll have the repetition that'll become easier the more we practice it. All right, so that's the end of our indirect care lesson. So if you have any questions on anything that we went over in this, please don't hesitate to reach out to us and ask. As you can see, my email is right there, k4@h2health.com. Once again, any questions at all, please don't hesitate. Thank you.